So who was the woman you said is 117 years old?
Emma Morano is her name. Yeah.
Emma Morano. She's Italian?
Italian, yeah, from Verbania, Italy. Yeah.
Wow. What are the main causes beyond diet of her living a long, healthy life?
In her case, it was genetics, right? And we knew, I mean, you're never 100% sure, but you're pretty sure because when I asked her, tell me about all your brothers and sisters and your mom and father.
They all lived old.
All of them but one over the age of 90.
Oh my gosh.
And the chance of that is 1 in a billion, probably,
Wow.
right? So yeah, extremely unlikely that by chance a bunch of people in the same family, virtually everyone out of 10 people will make it to 90. Yeah.
So that's a gene type of thing. What is the gene that she has or her family has, and is there a way that we can trigger those genes in ourselves?
Yes, with nutrition, with the longevity diet and the fasting making diet and a few other things. Yeah, so we've been following now for 15 years this population in Ecuador, and they're little people, right? So they're about 3 feet tall.
No way. 3
Yeah,
feet?
3 feet tall, yes. And they're lacking what's called growth hormone receptor. But why are we studying these people? Because if you remember our first discovery of the genes that control aging in microorganisms, it was in the same what's called pathway. So these microorganisms that live 10 times longer, they are little, right? Yeah. So and then the work by John Kopchik and Andrei Barkey here in the U.S. showing that the mice that have record longevity extension, they're little mice, right? With the same mutation in the same gene, the growth hormone receptor.
Both you and I are kind of tall though. Are we screwed?
No, not necessarily, because we know that we can intervene, at different stages of life, right? So you can intervene. You can start a nutritional intervention or a pharmacological intervention on a mouse at different stages. Of course, the earlier you start, the bigger the effect you see. But you can still get a lot of the effects later in life, especially if you consider that that's from diseases, right? Right. If you switch your nutrition, even if somebody was 60 years old, they could still make a big difference.
You could still extend your lifespan and reverse diseases at 60 potentially.
Yeah,
Wow.
Almost for sure. I mean, if you consider that. Yeah, if you consider cardiovascular disease and diabetes alone, I mean, those you can truly revolutionize, let's say, the chance of developing them or having them progress based on a clear and strong change in your diet.
Wow. What were the other factors beyond nutrition that you think are allowing her to live a longer life?
Well, the big factor was Carlo Bava, her doctor, right? Big factor. Why? Because Carlo, the attention, and we saw that when I visited Monte Carlo and San Marino, some of the places that have the highest longevity in the world. I realized that one of the major reasons is that they have such a close attention to the old person, right?
The doctors do?
The doctor, the medical system, right? So they for example, in Monte Carlo, if you're older, they can bring you the food at home. They have ambulances very close by. They have a safety system
for older people.
For everybody, but for older people that make sure that if you get a heart attack, they're going to be there very quickly, or they're going to catch it early, or they're going to give you the test, right? So yes, that's how Carlo Bava was with Emma Morano. He made sure that she got checked. She got treated. He had to do some blood transfusion. I think he did them at her home because she didn't want to go to the hospital. So she would have probably made it to 100 on her own, but to make it to 117, I think it took a very inspired physician.
So it's regular checkups. It's prevention of things. It's not just going through life saying I'm fine. It's going to do a checkup once or twice a year and making sure blood levels are good and everything's good. Is that right?
Yeah, I think that having somebody follow your nutrition and have the right people follow your nutrition is key.
Interesting.
But at the same time, are you gonna get a colonoscopy or not? Are you gonna check your fasting glucose level, the HbA1c? Are you gonna have, if you have high blood pressure? Are you going to intervene strongly enough against that without resorting to drugs, right? So the idea is, as you introduce drugs, and the more drugs are in the system, the more the system now is going to adapt, change, and now each drug can cause another problem, right? So then ideally, you want to try to keep everything working without drugs, which is very difficult to do, and that's why you need probably a team that helps you get there.
Let's say you have unlimited resources. Let's just hypothetical situation. You've got unlimited resources, or you've got a certain amount of money to dedicate towards a nutritional health doctoral team a year. Who would you want to have on your team, or what types of people should people be looking for on their team? Is it a nutritionist? Is it a specific type of doctor? Is it a trainer? What are those people that we should be looking for?
So we're trying to do that both in Italy and here in Los Angeles. And so we have physicians that are in internal medicine doctors, and they are integrative type of doctors. So they understand, they appreciate the integration with other intervention that could be nutrition, exercise, etc. Then we like to have at the clinic dietitians that have higher degrees, right? The type of person that might focus on nutrition might get a PhD, right? And then ideally a psychologist. We don't have that yet because we're still small, but I think that would be very helpful. And then the collaboration, which we have, luckily, with lots of hospitals all over the world, right? So in each case, we look for partners usually we do clinical trials. But our partners include MD Anderson, Mayo Clinic, Cleveland Clinic, and so as we develop clinical protocols, then we go to some of the leading hospitals, and usually the leading hospitals are very open. They like things that are different, and they're looking forward or forward-looking, and So I think that eventually it'd be nice that everybody had that, right? Everybody had so let's say you come to our clinic, and then based on the problem, the clinic says, I think you should be treated by this oncologist or this cardiologist or this immunologist, because they're probably the ones that are gonna work with the team in a way that minimizes maybe the drug interventions until you do need the drug intervention. For example, in cancer trials, it's all drugs, right?
Yes.
So it's fasting mimicking diet plus the drugs. We've never seen any evidence that doing it without the drugs is going to be helpful.
How much of a negative effect does taking drugs consistently in your life affect the longevity of your life? Either a little bit of drugs or medication or a lot of drugs?
Yeah, nobody knows, right? Because I don't know that there is any formal studies on this. But I think that the body is in a perfect equilibrium.
Yes, so harmony.
Everything is perfect. It was nearly perfect, let's say. And so, for example, if you think about cholesterol, right? So now you have a statin. So this drug is now going to block cholesterol synthesis. Well,
it's going to cause a different problem, right?
Yeah. Is that good? Well, yeah, it's good because it's lowering your blood cholesterol. But at the same time, you have to ask the question, why were you making all that cholesterol? What are you trying to do with that, right? So the cholesterol is involved in making hormones, in building cells. So what happens when you block that, right? So then you have to consider that lots of drugs are blocking things, and they're not necessarily blocking things in a sophisticated way, right? So they're not, let's say, go after the cholesterol synthesis. And say, oh, I'm going to allow this type of cholesterol to be made, but I'm going to, affect some other subtype, Usually they're pretty rough, right? So of course, things are getting better. In some cases, there are more sophisticated drugs. For example, those that are targeting the immune system, they try to, let's say somebody has an autoimmunity, the drugs are trying to go after only a subset of immune function, so they don't take away your normal immune function. But most of the immune drugs will say, the chance of infections is going to go up, and the risk of death from this and that. Yeah, so that means that when they ran the trial, they observed that the risk of certain diseases or infections went up, and it's not surprising. Now you're blocking something else that is trying to help you, right? But that is also hurting you by, let's say, attacking your own cells. So no matter what system you look at, what type of drug, cancer drugs, right? Let's say immunotherapy. Well, lots of good, right? Because it changed the survival in several types of cancers. But then again, now some people are gonna have the immune system attacking the normal cells, and so there's lots of side effects caused by immunotherapy, right? So I think that
so it's best to figure out what's the root cause of it. Try to get to the root first before using the drug, is what I'm hearing you say.
Yeah, let's take diabetes. Let's take the doctor that we were talking about earlier, right? So he's got diabetes, got hypertension.
He had 4 medications he was on.
4 medications, right? So, and he was going to be on his way within, I would say, 2 or 3 years of having to inject insulin, with the pancreas being, irreversibly damaged, right?
Wow.
So right there you see that what should have been done. He knew how to do it. Now you could say, oh, lots of people are not going to be able to do it. Well, of course they're not if they don't have the team, right?
Yeah.
If they
It's
don't
hard to
have
do
the
on your own.
team,
Yeah.
and we already see, for example, in Holland, we did a clinical trial, a multi-center clinical trial, where we did not have a centralized registered dietitian calling people up and knowing the system and the compliance. So the percentage of patients that did more than 3 or 4 cycles of the fasting making diet together with chemo went down to like 35% or something like that. When we do it with the dietitian calling you, then we're up 70, 80, 90%, right?
So you mean just the dietitian calling you for accountability, to check in once a week or once a month and saying, are you doing what you're supposed to do? And
how are you feeling? Here's what you can expect from this, right? How are you feeling? Did you eat anything else? Can I help you? Yeah, so that completely changes the ability and the willingness and of a patient to do it. So I think one thing is to say to a patient, change your diet, and one thing is to say, don't worry about it. We got the team. We're gonna help you. And at the beginning, you're gonna have lots of questions, lots of calls, and then after a couple months, you're gonna say, I don't want to talk to you anymore. I know.
Yeah, I got this. I'm doing it. I'll check in less. Yeah.
I'm doing it, and now you have continuous glucose monitors. We use that on this doctor, for example, right?
Really?
So we were able to without him even seeing it, we were following his fasting glucose, adjusting to it. So we would call him and say, okay, what did you do? Did you eat something last night? And last night I had a big dinner. And so I think that the technology is a big help. So that just in also making it easier for the clinic to do the job.
Did this doctor, was he obese as well, and did he lose a lot of weight in this process?
He was overweight. He lost weight. He didn't lose. It wasn't somebody that lost 40 pounds,
Right.
He must have lost, I don't know, maybe around 10 pounds or something like that.
But he reversed a lot of the challenges internally in his body.
Well, that's a trick, right? It was losing weight, but that wasn't so. So there seems to be two factors, right? One is going after, let's say, blood pressure and other issues that he had. But that wasn't really changing his insulin resistance, right? So that was solved by the fasting mimicking diet. And so there's probably that switch that keeps the body in let's store fat to let's use fat, and that's what needs to be unlocked. So that the combination of the correct everyday diet and that a diet that forces that unlocking process seems to be key. I think it's always good to have a reductionist approach and think of the human being as a plane or a car, something that is complicated, sophisticated and complicated. How do you? I always use it, for example, when people ask, shall I go running, 20 miles a day, or shall I never run? Well, I always say, well, if you keep your car in the garage all the time, not good, right? If you drive your car all the time, not good either.